So if people can just switch on their videos. And Jackie, I think there is a question or two in the Q&A. If you don't mind, let's address this.
So the first question, the Q&A was asking about employing negative pressure systems to prepare the bed for grafts or bone transportation in cases of osteomyelitis.
So is that for Peter, maybe?
I think so.
So like vacuum assisted, right?
That's my understanding of the question.
Okay. So Peter, if you don't
If
mind, just restate the question for the participants as well, and then if you can please respond.
I think the question was, what's the role of negative pressure dressing in preparing for bone grafting in chronic osteomyelitis? So the first thing that I want to just say is, at the first stage of debridement in in these cases, this is a very hyperemic limb. So you just have to be careful with negative pressure dressings in that setting, because you can exsanguinate the patient if you're not careful. So that's the first thing. So you just have to monitor bleeding very carefully. We don't routinely use it. I think there may be a place for using negative pressure dressing on top of a flap closure. That has shown some good results. Um, and in terms of if you're not planning a bone graft and you've got a big soft tissue defect that you're planning to put a split skin graft on, I think, and you're planning to do a different kind of reconstruction procedure, perhaps like a fibula transfer, then I think that could also play a role. But I think you're going to struggle to do bone transport when you've got an indurated, scarred bed that's been closed with a negative pressure suction dressing. And also there's the risk of secondary infection with hospital-acquired bacteria. So there are problems with it. Obviously, when you're using negative pressure suction dressing, then often you're dealing with a complicated patient. So I wouldn't say there's no role for it, but be careful. There's the risk of exsanguination, the risk of co-infection, opportunistic other infections. So probably not in my experience. I would use a different technique, but I'm not saying that there's no role for it.
Miguel, Scott, or Reggie, or anybody else? Other Chris? Any other thoughts on this? No? Good. All right, that was great. Jackie, any other questions?
There's one other comment in the question answer. It's not a question. It's seeking a volunteer therapist who could help with upper extremity children with arthrogryposis and low resource location, and then has an email address if anyone knows of someone who could be of assistance.
Okay, I guess that's more personal, and maybe somebody in the audience can respond. Okay, so this is our last poll. We have two questions. So let me try launching this. And please, participants and faculty can respond. You guys see this? So it's kind of, because this is a very eclectic group of topics. The first one is on managing bone defects. And I think we're just trying to see which of these techniques do you feel most comfortable when managing bone defects? So it's only a single choice answer. Masculate, limb shortening with lengthening, acute shortening, followed by lengthening at a different site, bone transport, equally comfortable with all three techniques, and other. So I'm assuming it's like for a similar size defect. And so it's a little bit of an unfair question because you don't have all the info. But it seems like masculate seems to be the winner here, followed by limb shortening and lengthening. Okay. And I'll share the results in a second. Then the second one is about how many cases have you performed involving 3D planning techniques? And I guess 61% said none, and 17% said, I'm sorry, where are we here? Give me a sec. Yeah, so 17% have done, more than 10. So that's impressive. So it is a little bit of a spectrum here. So that's good. And I wonder, because I know like there are surgeons in India who are doing local 3D printing and, making guides at a very low cost. So I think that's also a possibility. All right. Miguel, can I ask you a question about your technique? It was so impressive to see all your Lazaroff hip reconstructions, including the one from your professor from, 46 plus years ago. That was great. You should publish that. Um, so the question is, so you showed a bunch of kids with plates, which I guess you could take the fixator off early. And my question is twofold. One is that the few that I've done, the Lazaroff reconstructions, a fair amount of them had knee stiffness, some of which whom needed, quadriceps plasty. So if you're putting a plate on, does that make it even more stiff or not because you're taking the fixator off early? And number two is the obvious question of infection. And number three is, do you take the plate out or only if needed? So sorry, a lot of questions, but I'm intrigued.
Yeah. Well, it's fantastic when you change the external fixator with a plate. The bone is going to heal better. The knee is going to be free. Actually, you can release a little bit the quadriceps with your finger in the distal part. Because I do two incisions, and the plate is not lateral; it's like a anterolateral, and I put it with external fixator on. I have a kind of protocol to cover everything, a very precise protocol to cover, and then we start to put the plate. And the plate's gonna be like a sign of a dollar, It's like the plate's gonna be straight. Sometimes you have to bend it a little, sometimes not, because it's gonna kind of anterior and lateral, anterolateral. And stiffness, yes, we have to deal with that, with the stiffness of the knee, but most of them recover, all of them recover, but they need physiotherapy that you can start very early when you put the plate.
Yeah. So if I understood it, so you take the fixator off and then you kind of do a submuscular plating for the most part, unless you're going to do a
I
quadriceps.
put the plate first. I put the plate with the external fixator on.
Oh, so you go,
And
that's what you
then
were saying. Okay, you go more anterior to the pins.
yeah,
Okay, got it.
that's right.
Okay, got
Yeah.
it. Scott's got a hand up. Scott, please.
Yes, I was very interested in the same thing. That those pictures with the plate are really amazing. And I was wondering if it affects your rate of remodeling, because my experience has been, and also in reading other reports, the kids that have PSO at the age of less than 10 years old oftentimes remodel. And I noticed that you were doing it on some younger kids. Do you think the plate prevents remodeling to a certain extent or protects against that?
No, but because we took out the plate, we take it out very early. I mean, the plate is gonna be only maybe 3 or 4 months because it's gonna heal very fast when you put the plate. It's gonna be fast. So when I do the lengthening, any nerve lengthening, I put the plate on not only in pelvic support. I put the plate in any lengthening. We call it we change the plate, and the surgery is called changing the external fixator for a plate. So the patient is going to be lengthening 5 centimeters. So the external fixator is going to be for 3, maybe 4 months. Then once we reach the quantity of centimeters you want, the same day we do the order for the surgery. Maybe it takes 3 or 4 weeks to be in the OR. So then we take the plate. With the question of the remodeling, that maybe in the 6 years old, 8 years old, we see that remodel, but it still function. I mean, because we had the opportunity to do the lengthening. And that's very important. And some of them, that because they are very young, some of them develop kind of a joint with maybe a piece of head that was there. And when you do the valgus osteotomy, I show you in this, but I have a lot of them that they develop a kind of joint that is that's different to do pelvic support in an adult. That is a real pelvic support. This one is kind of a trick to put the maybe the piece of physis or something that used to be a head, and you put it in the acetabulum when you do the external fixator. In some cases that works, in some cases not. But if they remodel, no problem. They will function again. And also, we have to follow these cases for years, and we can do another another pelvic support later to do another lengthening. I have done that too.
Great. If I could just ask one more question on that same subject, I'm wondering, I saw one case where you had a femoral head that was still in the acetabulum, and I'm wondering if you ever do hip fusions for the situation where you might have like a stiff, painful hip, or if you always prefer to do pelvic support osteotomies.
Pelvic support. I don't like the fusion in the hip, at least.
You seem to take down fusions, huh? And those patients do okay too?
And which ones?
You said you took down fusions, like you showed a case of a fused hip where you took down the fusion in the hip, right? Yeah. How do those patients do?
Fine.
Yeah.
Because I do a kind of Gilderson.
Yeah, Girdlestone. Yeah.
Yeah, Castro or something like that. And then I do the pelvic support. That they works. I have maybe 3 or 4 of them, but I have no more. Yeah. I mean, it's rare that the patients, the children do a fusion. It's not common.
Well, you should definitely, if you haven't done so, please write up your series. It's going to be very helpful to a lot of people with all the technical details. Okay, well, we've got about 10, 12 minutes. Does anybody want to show a case? Like I have a case or two I just thought we could share. So let me do that while people are thinking about it. Okay, let's see. Not this one we talked about. I think we've talked enough about congenital shortening. So I was thinking maybe let's do this one. This is sort of a post-septic case, and I think we could even involve Ola here because there was a physis issue. So Ola, we'd be interested in your thoughts as we go on. So this is, let me see if I can change that to a share mode. And for some reason, I can't move this. In 1 second. Oh. Okay. Can you guys see my screen? Right?
Yeah.
Okay. So it's a 7-year-old female who actually I saw not too, like maybe 2-3 months after I moved to California. And she had a history of septicemia as a neonate, as a 1-month-old. And I think she had like a couple of debridements. And make a long story short, she had a post-septic growth arrest of her left distal femur. So she's 7 years old. She has about a 5.3 centimeter leg length difference. And those are her numbers. And she's standing on a shoe lift here. So just for moving this along. So she's got varus in her left distal femur. She's actually got compensatory valgus in her left tibia, which is not uncommon. And then, Ola, if you don't mind, look at the knee x-rays and tell me what, if any, role would an MR have for something like this? I mean, here it's almost redundant because we know what it's doing. But if you saw a patient or if we saw a patient like this, prior to a deformity, can the MRI with DTI help us in any way?
So the thing is that what we are thinking about is or our suggestion is that we can see quite early on. We start to look now actually on some fractures to try to figure out when we see a Salter-Harris fracture on the X-ray to do if we can do a follow-up to see what's happening with the growth plate. And then we actually look at two things. One of it is that we try to look itself at the water content to see do we see already there that the amount of chondrocytes or cartilage is getting affected. And the other portion then is, can we see that with diffusion tensor tractography, this mismatch? And what we hope, big hope, is that if we can find this earlier while the growth plate still is being somewhat active, we can have an intervention and sort of either then try to repair or help the injured side to become healthy so we don't get this fusion, or the other way around, then that rather than we have this deformity, then the question discussion for you that are the expertise regarding bones is then should we try to make a symmetrical fusion and then in a later stage have a bone lengthening procedure, but then you don't have the deformity, but you have more symmetrical and the joint itself is being the way we want it to be.
Yeah, no, that's true. And I think we've all had cases where the MR actually didn't show a bone, a spot weld or a premature physeal closure, but physiologically it acted like a physeal closure, partial. So here's the MR. We didn't have the DTI. And anyway, and please, people can chime in or ask questions at any point. I'll just keep moving for the sake of time. So, and the reason I'm showing this is because there were successes and there were failures and there were different techniques used here. So my plan was to ablate the physis and put on a hexapod to correct her length, alignment, and perhaps even over-lengthen her a little bit, given that she's still young and growing. So, and you can see the induced intentional, translational deformity. Any comments, critique, suggestions so far? Would people have done anything different? No? Yeah. Chris?
I have some cases.
Yeah. Oh, yeah.
Go ahead.
Go ahead, Miguel.
Chris.
We've really gotten away from frames on femurs as much as we can. I mean, it's by far the most miserable group of patients is anybody with a frame above the knee. So, given Ray's talk earlier about retrograde nails, I mean, this, in my case, with the already demonstrated physis, it's not going to work. We would probably just do reverse planning with a retrograde nail to straighten. And then if it fit an internal lengthening nail, then do lengthening with the nail at the same time, or potentially just have it ready for the future. And then do a guided growth on the tibia to get the valgus correction, but not a fixator if we could avoid it.
Okay, so what if the canal was too small for whatever the 8.5 nail? You would just wait and give her a shoe lift?
Well, if the alignment was an issue, you could still find a nail that you could do straightening, then just have that nail living in there until you could do the lengthening, but
okay. Yeah.
Just avoid the fixator.
Okay, but then she's going to be a little short. Okay, I think somebody else was Miguel. Let Miguel go, and then I think it's
yeah.
Go ahead.
Yeah, what I do, I do a lateral approach of the distal femur. I close the physis with the old Femister technique, and I put a plate. I do maybe a little shortening, maybe some centimeters, and I put a plate, put it straight, and some months later, maybe 6 or 8 months later, I do a surgery taking out the plate and put a monolateral external fixator, but in a straight femur. I mean, it's too, the 5 centimeter is too long to wait for to put a precise. So I think you have to do it with or should do it with a external fixator as soon as happens.
Yeah. Okay. And your quick comment, because then we'll move. Go ahead.
Yeah, so just to add to what Dr. Yoop said, you had asked a question about the nail and a canal that's too small. So Dr. Yoop has a series where he has used the extra medullary lengthening nail and has been able to achieve angular ang, ang, angle, angle, angular correction at the same time as well. So that's another option.
Yeah. Yeah, that's a good point. Yeah, you're right. Reggie?
Well, I agree. You close the faces laterally, you realign it, and why you don't do using a monolateral fixator, the correction and some gradient correction?
Yeah, so she actually had, that's a great question. So firstly, these are 2/3 rings, so you're right, it's more bulky. Secondly, she had some sagittal plane deformity as well. I don't think it came out nicely on the thing. So I think in my hands, if you've got a biplanar deformity and it's long-standing, I somehow, maybe it's just my bias and experience that I just, yeah, the patient suffers, but I think it's a little easier for the surgeon to then correct things in transition. As we know, with monolateral, once the train leaves, it's gone. It's very hard to change tracks. Okay, but that's kind of an unresolved point. Let's go on. So then fixator comes off. I do a prophylactic nailing to protect the lengthening regenerate. How many people are doing that for femoral lengthenings, protecting the regenerate with intramedullary implant? Anybody? Scott, go ahead.
I do.
I was just raising my hand that I do it. Yes.
Okay, all right, awesome.
Absolutely.
You do for both congenitals and non. Yeah, congenitals and non. Okay, good, perfect. And I mean, yeah, go ahead. Sorry.
Well, just another thing on this case. When you have this much lengthening to do, she already has 5 centimeters deficit. There's going to be more lengthening in the future. And ultimately, once the deformity is corrected, lengthening it proximally is going to be a little bit easier. So that's something that could be considered in the overall picture here too, with whatever combination of techniques of using precise or a lengthening over nail. But I think you got the deformity nicely corrected here. Now you have intramedullary, and you're perfectly set up to take another step with hopefully a magnetic nail or something like that.
Okay, so 2 things happened. One, magically, her valgus got a little better in the tibia. I don't know how. I can't totally explain it. But number 2 is that she started drifting back into varus. So the June 2020, you can see I had her pretty anatomically aligned, but then she started drifting into varus. So I got another MR, and sure enough, I didn't ablate the entire physis that I thought I did, which, can happen. At least it's not the first one that's happened to me, where you drill it and then you're going to put a fixator on and you're like, I don't want to soften too much of the bone. And so here we are. So what would people do now? Anything? All right, well, we're moving. I just basically did belts and suspenders. I scraped it and I put a plate there just so that we don't lose anything, and at least it doesn't get worse. And then, as was predictable, over the next 2-3 years, she got a growth spurt. The varus was there, but it didn't get any worse. But her leg-length discrepancy increased because she had a closed distal femoral physis. So then here we are. So, oops, I kind of gave it away, but sorry. So what would people do now? Miguel, what would you do?
Well, maybe it's 4 centimeters, and now it's an older patient. I mean, looks like the diameter could fit a precise. It could be a patient for a precise.
Yeah. Or would you go antegrade, retrograde?
Good question. I'll do it retrograde. Yeah, I think it's to correct that. I have the opportunity to correct the varus with the retrograde nail. Yeah.
And okay. And do you believe that if you're lengthening with an antegrade nail, as you lengthen, it's going to go into more valgus or not? Would that self-correct, or that's hard to figure out?
No, you have to correct it acutely. I mean, you have to correct it acutely with the nail.
Yeah. Yeah. Okay.
Another option is to do it with a monolateral, but if you can do it with a precise.
Yeah. You mean monolateral and do a lengthening over nail if you don't have a motorized lengthening nail?
Yeah, but I don't use if you use monolateral, you don't need the. Well, it's my opinion. I don't use lengthening over the nail. I mean, if you put the monolateral in the right position, it will works nicely. Yeah.
And then once it's lengthened, do you intramedullary nail it?
I use a plate.
You use a plate. Okay, got it.
Yeah.
Okay, very good. Okay, well, so again, for the sake of time, that's sort of we did a retrograde nail, and just to show, and I think Chris and others have really beautifully written and demonstrated the technique. So using blocking nails, and now I think some of our fluoroscopy machines actually you can measure angles. So I think just to show that sometimes you have all this technology at your hand, and not to say that it's good or bad, but I think there are a lot of creative solutions that can be done even if you don't have this technology. So nothing too fancy here, but the intentional translation and a slight bit of vericization, well, not vericization, but undercorrection to see that as she lengthens, it realigns the mechanical axis. So I just saw her actually 2 weeks ago. So she's nicely consolidating. Her leg lengths are equal. She's done growing. And, I think that's sort of the game changer has been preserving her knee motion through all this. And so I think definitely in that sense, the internal lengthening nails have helped. But not to say that you can't do that without an internal lengthening nail. So I think we'll stop here. Any last minute questions? Comments? No? Okay, well, I think it's been a great webinar, and thank you everybody for joining, including our participants and of course our esteemed faculty, all our support staff, my two co-chairs, Dr. Hill and Alex Giraldi, all the admin people who've really supported everything in the background, especially Caitlin and Ryan, and of course KJ. So what's going to happen now is I would really love to hear feedback from everybody, candid feedback in terms of what you thought went well, but more importantly, what we could improve for next time in terms of content, presentation, timing, et cetera, et cetera. So please give us suggestions. And so you'll be getting a survey via email, or I don't know if Ryan's going to put it in the chat for now. Let me see the chat. Yeah, so Ryan's already posted it. So please click on it and do take the survey before you leave, if that's feasible. And you'll also get something in the email, especially for those who are going to want CME credits. But even if you're not wanting CME credits, I think your feedback is highly, highly important. So this has been a real enjoyable day for me. And thank you again for joining.
Thank you. Thanks, Sanjay.
Thank you. Thank you all. Can the local faculty and admin please just stick around, and everybody else can leave. Thanks again.
Thank you.
Yeah.
Thank you. Have a good evening.
Yeah, you too, guys. Good night for most of you.
Thank you, Sanjay.
All right, Miguel. Thanks, man.